Our lecture today is about carcinoma of the cervix. If the CIN, which is the pre-malignant stage of cervical carcinoma, is left without a treatment, there is a chance of invasion of these abnormal cells through the basement membrane into the stroma, and then it will change from a pre into a micro-invasive disease, and this small group of cells may increase to become a larger lesion. We have the micro-invasive carcinoma of the cervix, and these are asymptomatic group of patients, and the patient has no obvious lesion on examination. It is a very early disease status and can be treated by local methods because the risk of spread to the lymphatic nodes is very low. The main cause correlated with cervical carcinoma is the human papillomavirus, and this virus can be correlated to other malignancy of the genital tract system. We have risk factor for developing cervical carcinoma, which is sex at young age group. If the woman having sex with a person infected previously with HPV, and if there is long-term use of combined contraceptive pills, if there is positive family history for cervical carcinoma, if the woman having depressed, or if the woman having depressed immune system, for example, she had an HIV, or she's on immune suppressant medications, or she may have steroid dependent diseases, for example, she is liable more for having cervical carcinoma. Also, women with multiple sexual partners and women who is a smoker by passive or active smoking. Also, women with multiparity are risk for having cervical carcinoma. The clinical features: the woman will present with abnormal vaginal bleeding, and this abnormal vaginal bleeding either in intermenstrual form or in postmenopausal type. Women in reproductive age group will have postcoital bleeding, which is a common symptom of them. Some women will have profuse offensive vaginal discharge, and this can be blood stained. If an advanced disease or later presentation, the woman will present with pelvic pain or backache, or sometimes she may have leg edema, severe cachexia or weight loss, and hematuria or dysuria or bowel changes. So in any woman with abnormal vaginal bleeding, there is possibility of either cervical or endometrial carcinoma. By examination, if we put a speculum and look at the cervix, there may be a small nodule or ulcer, and it may bleed on touch. Or we may have a crater-shaped ulcer or friable warty-like mass or growth. With the progression of the cervical carcinoma anterior or posteriorly or laterally, there is fixity of the cervix and immobility. These pictures shows to you different shape of the growth of the cervix. The diagnosis by taking detailed history and doing clinical examination by speculum, and sometimes the patient is preferred from the colposcopic unit because of suspicious features in the examination, and the biopsy is taken, or sometimes we review the previous biopsy and see if there is microinvasion. And this biopsy is important also for the staging of the disease. The staging of the disease is usually by clinical staging. This picture shows to you two types of biopsy, either by punch biopsy or by doing cone biopsy by knife. The staging of the disease is usually clinical, as we mentioned, by examination under anesthesia, EUA, which include rectovaginal examination also. We should take biopsy from the suspicious area and study it by histopathological examination, cystoscopy to check the bladder or ureter, sometimes doing the IVU or IVP, sigmoidoscopy to check if there is any growth to the rectum or to the sigmoid, chest x-ray, CT, and MRI of the abdomen or the pelvis. The staging of the disease involving 0 stage, which is the CIN3, stage 1, which is usually the growth is limited to the cervix, did not get out of the cervix. We have two types, either it is a preclinical or clinically seen growth. The preclinical is usually diagnosed by microscopy. We have stage 1A1 where there is minimal invasion, less than 3 millimeter depth, or stage 1A2 where there is microscopical invasion but still less than 5 millimeter. Stage 1B, the growth will be more than 5 millimeter and usually it is visible. Stage 2, the growth will be beyond the cervix, laterally or through the parametrium, but doesn't reach the pelvic side wall. Stage 3, the growth will reaches to the pelvic side wall or to the lower vagina. Stage 4, it is an advanced disease either outside the pelvis or to the bladder or rectum. The survival is stage dependent, as we have early stages, better prognosis, and usually the 5 years survival rate is about 60%. The pathophysiology for developing cervical carcinoma, usually the cervical carcinoma, it is of squamous cell types in 90% of cases. It resembles the epithelial covering the ectocervix. We have also adenocarcinoma, can growth in the endocervical glands, and usually the growth at the squamocolumnar junction. This area is more liable for the growth of the cervical carcinoma because of the metaplasia happens changing from endocervical to ectocervical cells, so it can be an nidus for starting to have malignancy. The pathophysiology involves any sexual activity, especially at early age group. There is risk for entry of the HPV virus. This virus enters into the basal layer of the cervix and it infects the basal cells and causing damage to the genetic material of these cells, and these cells are start to have these plastic changes to be a precancerous cells. The damage of the cells will continue to multiply and involve the whole thickness of the cervix. Sometimes the invasion of the basement membrane will occur, and then the appearance of cervical carcinoma occurs. We have two types of cervical carcinoma, as we mentioned, is squamous cell carcinoma and adenocarcinoma. Other types of malignancy have lesser incidence.